So burns. We are first going through long essay, burns, definition, classification, pathophysiology, degree of burns, area of assessment, and clinical features and management. First of all, coming to definition of burns. Burns are defined as an injury to the skin and or subcutaneous tissue caused by transfer of energy from heat source, electrical current, chemicals, radiation, or friction, resulting in tissue destruction and cellular protein denaturation. This definition is very important because when we think of burns, we only think of the thermal energy causing burns. It's not the case. An injury to the skin and subcutaneous tissue caused by heat, flame, and chemicals, radiations, friction, which is seen in road traffic accident, resulting in tissue destruction, is called as burns. I'll share the notes. Please be thorough with this definition. Next, we'll go on to classify burns. Classification of burns is very interesting as well as it's very important for exams. First, we will see classification of burns based on thickness of skin injured. The thickness of skin layer injured. Before that, let's briefly review the anatomy of skin, layers of skin. We have epidermis. We have epidermis, the papillary dermis, and reticular dermis. Please note, the blood vessels and neuronal structures are richly present in deep inside the reticular dermis. This point is very important. It will be handy when we are discussing about classification. This is the anatomy of skin, epidermis, papillary dermis, and reticular dermis, and the blood vessels and neuronal structure. Under classification, we have first degree burn, second degree burn, third degree burn, and fourth degree burn, with increasing severity from first degree to fourth degree. What is first degree burn? First degree burn is the burn which involves only partial part of epidermis. I repeat, in first degree burn, the only partial epidermis is involved. So it leads on to redness and painful redness, and the lesion will be visible as painful red lesion. And usually blisters will not be present in first degree burn. In this image, blisters have bursted, but usually blisters are not seen in first degree burn. No blisters. Since the blood vessels, the capillaries are not fully damaged in first degree burns, if you press the skin, the reddened area, if you press, it will blanch on touch. The first degree burn is involving partial epidermis, leading on to painful red lesion with no blisters and blanching positive. This is about first degree burn. Let's see second degree burn. Second degree burn is in turn classified into superficial second degree burn and deep second degree burn. What is superficial second degree burn and deep second degree burn? Superficial second degree burn involves complete epidermis and part of papillary dermis. It involves complete epidermis and part of papillary dermis. Superficial second degree burn. The deep second degree burn involves complete epidermis, papillary dermis, and the part of reticular dermis. When you go from first degree, second degree, superficial and deep, one structure are being added. First epidermis was present. In second degree, partial papillary epidermis got involved, and second degree deep reticular dermis got involved. You'll see in third degree, the entire thickness of skin will be involved. So I told second degree burn. In superficial second degree burn, only part of epidermis with papillary dermis is involved. So when this occurs, with time, the healing occurs with pigmentation. Usually we don't see scarring. Most of us has this superficial second degree burn. And then coming on to deep second degree burn, The deep second degree burn, as I already mentioned, it involves full thickness of epidermis, part of papillary, sorry, full thickness of epidermis, full thickness of papillary dermis, and part of reticular dermis. So when this reticular dermis is involved, it's usually always heals by scarring, and along with it there will be pigmentation. And also, since the reticular dermis is partially involved and the depth of reticular dermis is not involved, the sensations are intact, but blanching will be absent due to destruction of superficial capillary network. And also, the patient will be crying with pain. He'll complain of pain. In second degree burn, we saw superficial partial thickness, deep thickness, sensation intact, blanching not present. The patient will cry with pain. Next, let's proceed on to third degree burn. Third degree burn, the full thickness epidermis is involved, part of full thickness epidermis is involved, and full thickness papillary dermis and reticular dermis is involved. So entire thickness of skin is involved in third degree burn. And also, since the depth of the tissue is involved, the neuronal structures, the vascular structures are affected. So the sensory nerve endings are not active. The patient will be pain sensitive. You will surprisingly see the patient will not complain of pain, even though the condition is severe compared to second degree. In second degree, the patient will complain of pain. In third degree, the patient will not complain of pain. Since full thickness of skin is involved, the charred, parchment-like, pain-insensitive structure which is formed due to burn, you can see here the skin structure like this here. This is called as eschar. This is called as eschar, which is seen in third degree and fourth degree burns. And usually, always it requires skin grafting as a treatment modality. Next, in fourth degree burns, we see entire thickness of skin is involved. Now, what is left? Muscles and bones underneath are left. In fourth degree burn, the muscles and bones underneath the skin will be involved. This is about degrees of burns. First degree, second degree, third degree, fourth degree. In first degree, only the lesion, painful red lesion we will see. Painful red lesion we will see without blisters, and it heals by reepithelialization in 1 week. Please remember, the first degree burn heals in 1 week. Next, let's go on for second degree burn. We saw in second degree burn, full thickness of epidermis is involved with with involvement of papillary dermis in superficial partial thickness burn, and involvement of reticular dermis partially in super deep second degree burn. In second degree burn, we see blisters characteristically. If you see in the questions, if it's mentioned as blisters, it is second degree burn and above it. Also, in second degree burns, since the neuronal structures and vascular structures are not involved, the pain will be very severe and the patient will cry with pain. Sensations intact, blanching is not present as in first degree. This is about second degree. In third degree, we saw the charred parchment-like pain-insensitive structure, the charred skin called eschar is seen. And also, usually it requires skin grafting. Here, it is pain-insensitive. The patient will not be crying with pain. In fourth degree burn, entire thickness of skin is involved, burnt, and the underlying muscle and bones are involved in fourth degree burns. This is about classification of burns based on thickness of skin involved. And also we have another classification, which is the easy one. See, what happens in first and second degree? Only the part of skin is involved. Full thickness of reticular dermis is not involved. Full thickness of skin that is deep into the reticular dermis is only involved in third degree burn. So first and second degree burns are called partial thickness burns. Third and fourth degree burns are called full thickness burns. That's it. You can mention these things separately. First mention first degree, second degree, third degree, fourth degree burns, and then Another classification based on thickness of skin involved, you can mention partial thickness and full thickness. In that you can mention first and second degree and third and fourth degree, and as example of these two. By this we are completing with classification of burns. We are done with definition, classification, and degrees of burn. Let's go on for pathophysiology of burns. Pathophysiology of burns. We all know that what's happening when there is any energy which is causing burns. There will be coagulation of proteins and the tissues in the skin and subcutaneous tissue. Due to this damage of skin and subcutaneous tissue, there will be release of vasoactive peptides like bradykinin. This bradykinin is potent vasodilator. This vasodilation, along with damage of capillaries, will result in impaired capillary permeability. That is not impaired, we can mention increased capillary permeability and loss of plasma proteins and fluid to the external environment. This loss of plasma proteins and fluid to the external environment will result in severe hypovolemia. Severe hypovolemia will cause reduced cardiac output due to the myocardial ischemia. See, when the blood supply is reduced all over the body, even the myocardium blood supply will be impaired. The body will try to maintain brain and myocardial perfusion, but in severe hypovolemia, heart will also get compromised. Due to that, there will be reduced cardiac output. Reduced cardiac output when the left ventricle cardiac output decreases. There will be back pressure leading on to pulmonary edema. And also, since cardiac output is reduced, the fluid inside the blood is lost, there is reduced systemic perfusion. What reduced systemic perfusion causes? It causes acute renal failure. We discussed 2 days back. Acute renal failure due to prerenal and also due to renal cause. How prerenal and renal cause? Prerenal because there is reduced blood supply leading on to ischemia and activation of RAS system and other system leading on to prerenal failure. Reduced blood supply causing acute renal failure. And also when there is 4th degree burn, it causes injury to muscles. Injury to muscles will release myoglobins into the blood. The release of myoglobin into the blood will cause myoglobinuria. This myoglobinuria is toxic for tubules. It causes acute tubular necrosis. We already discussed this. So thereby, here acute renal failure can occur in burns due to 2 reasons, that is prerenal and renal, reduced blood supply and acute tubular necrosis. Remember this point. What are the GIT manifestations of reduced systemic perfusion? When the blood supply to the gastric mucosa is reduced, the mucosal defense is impaired, and also due to ischemia following reduced blood supply, there we see stress ulcers called as Curling's ulcers in the GIT. So in case of any stress like burns, surgery, or any major events, we should give proton pump inhibitors to the patient to prevent stress gastric ulcer, also called Curling's ulcer. Please remember this point. Curling's ulcer is a 3 marks question in itself. So I briefly touched upon it. You can mention causes of it, pathology of it, and then you can mention few examples and treatment, that is giving the patients proton pump inhibitors. Okay, this is about. And also, since the skin and subcutaneous tissue is damaged, the organisms thriving in environment get free access to the body. So there is increased chances of infection in case of burns. Secondly, badly the patient may develop sepsis, severe inflammatory response syndrome, and at last he may develop multi-organ dysfunction syndrome. which is associated with high mortality. So I discussed about pathophysiology. First, there is damage of skin and subcutaneous tissue, release of vasoactive peptide like bradykinin, leading on to increased capillary permeability, loss of fluid and electrolytes to the external environment, severe hypovolemia, leading on to reduced cardiac output, myocardial ischemia, pulmonary edema, reduced systemic perfusion, leading on to acute renal failure, JIT manifestation like Curling's ulcer, and then we saw there is increased risk of infections due to loss of innate immunity, that is the barrier of skin, which may lead on to severe inflammatory response syndrome and multi-organ dysfunction syndrome later. This is about classification and pathophysiology of burns. Let's proceed on for assessment of burns. How to assess burn? We have heard this many times in forensic medicine, and also in class it's mentioned many times. In adults and children, it's different. Wallace rule of 9. And also we have palm method, where the patient's palm area is 1%. So by placing the patient palm, looking on the size of patient palm and comparing it with the size of burn, we can estimate percentage of burn. But the most important method of assessment is Wallace rule of 9. It's asked as 5 marks question also. Please pay attention. So in adults it's different, in children's it's different. In adults, head and neck is considered as 9%. Front of chest and upper abdomen is considered as 9%. The back is considered as 9%. The front part of upper limb is considered as 9%. 1 minute. Yes, the front part of upper limb 9%, back part is 9%. The abdomen is considered as 9%, other 9% is of back. The upper part of leg 9%, lower part 9%. Perineum 1%. By this we get 100%. I'll repeat: head and neck 9%, upper limb 9%, front of chest 9%, upper abdomen 9%, perineum 1%, upper part of thigh 1%, legs 1%, sorry, thigh 9%, legs 9%, accounting for 100%. And in children, head and neck is considered as 18% because they have more surface area in head and neck region. And upper limb considered as 9%, same as adults. And upper chest and abdomen considered as 9% each, same as adults. But there is difference in lower limb. Here lower limb is 9 plus 9, 18%. Entire front part of lower limb combined is 18%. In case of children, from here to here, that is entire lower limb is considered as 13.5%. And perineum as adults 1%. Based on percentage of burn, again the burn is classified into mild, moderate and severe burn. Mild burn, in case of partial thickness, if the adults have less than 15% of mild burn, and if the children have less than 10% of partial thickness burn, that is first and second degree burns, it's considered as mild burn. If the adult or children have only less than 2% of full thickness burn, that is third degree and fourth degree, it is considered as mild. Mild is partial thickness less than 15% in adults, less than 10% in children. Full thickness less than 2% in both adults and children. What is moderate degree burn? Second degree burns 15 to 25% in adults, 10 to 20% in children. Third degree to 2 to 10%, it's considered as moderate burn. And also there is important point to remember: if there is involvement of perineum, feet and face area, it's considered as severe burn. Even if it is comes under 15 to 25% burn, if these areas are involved, it's considered as severe burn. Please note this point. And the severe burn is all about the moderate burn. The numbers, if you want, you can remember, or else you can briefly mention about mild, moderate, severe degree burn based on percentage. That's your choice. This is about assessment. We are done with classification, pathophysiology, assessment of burns. Let's go on for clinical manifestations. What are the clinical manifestations of burn? Most of it we already discussed in classification and pathophysiology. In the burnt area, in case of first degree burn, we see redness and painful redness, painful red lesion. In case of second degree burns, we see blisters with sensations and no blanching. In third degree burn, eschar we will see. In fourth degree burn, we'll see eschar and involvement of muscles and bones. This is about burnt area, clinical manifestations in burnt area. What are the systemic manifestations? We already saw here. Reduced cardiac output leading on to pulmonary edema, leading on to acute onset of breathlessness, and also features of acute renal failure like extravascular fluid expansion, hyperkalemia, and then acidosis, and also uremia and associated symptoms. GIT manifestations, curling ulcer, which may lead on to acute abdominal burning sensation in abdomen, paralytic ileus, acute gastric dilation. Yes, please remember this point. We can see acute gastric dilation due to filling up of gases inside the stomach following 2 to 4 days after burn. And also rarely pancreatitis is associated with burn. First of all, burn is severe disease. Along with this, another severe disease. It's very deadly. And also, we already mentioned that we can have infections in patients with burns. There may be infections of burnt area, or where we do IV infusion, IV catheters, or central line infections can be the bloodstream infection. The most common organism causing infections in burn patients is Staphylococcus aureus, as always. The Staphylococcus aureus secretes an exotoxin which is responsible for toxic shock syndrome seen in some set of burn patients. If the patient has toxic shock syndrome, the patient presents with rashes, fever, myalgia, and multi-organ failure. If we see these manifestations, please look out for toxic shock syndrome. Toxic shock syndrome is a separate 3 marks question in itself, so I mentioned it briefly. And also, if there is infections, we all know we'll have fever, lethargy, and leukocytosis. This is about clinical manifestations seen in burn. Mention about burnt area and systemic manifestations. Lungs, kidney, GIT, and infections. This is about clinical manifestations of burn. We saw classification, pathophysiology, assessment, and clinical manifestation. We are left with management. It's divided into first aid and definitive management. What is the first aid that we should give in burn patients? Burn patient. The first step is stop the burning process and shift the patient away from the burning area. This is most important. Without saying, all will do this. And this point is very important. Cool the area with tap water by continuous irrigation for 20 minutes, not cold water, as it may cause hypothermia because skin is already damaged. Tap water, tap water, tap water. Here, please. Don't mention cold water because it's burn. I'll apply cold water or ice water, so it may cool the area and the patient severity may decrease. Please don't think like this, because if you apply cold water, it will cause hypothermia. What is recommended? Recommended is continuous tap water irrigation for 20 minutes. Remember this point in first aid. Continuous tap water irrigation for 20 minutes. Next, we have in initial management, we have the removal of clothing, cooling of the part by continuous running water for 20 minutes, we know. Cleaning the part to remove any dust or mud which is present. And chemoprophylaxis, we should give tetanus toxoid. If the injury or the burn has occurred in the outside environment or at the environment where these tetanus infections are possible, we should give tetanus toxin. In all patients, we advise this, giving tetanus toxoid and covering the touching area of burn with different methods. We'll see that. So this is the first aid, continuous irrigation with tap water and tetanus toxoid. And then dressing. We'll mention about dressing while talking about definitive management. Then we have definitive management. Under definitive management, we all know first we should do emergency management, manage airway, breathing, and circulation of the patient. If needed, if there is involvement of face, and if there is upper airway involvement, if there is scoot in the upper airway, or if you see singeing of nasal airs, the upper airway may, with time, the patient may develop laryngeal edema and it may lead on to death. So please consider endotracheal intubation or tracheostomy in these patients. Okay, this is about airway, breathing, and circulation. Next, we have management of burns. In burns unit, we'll shift the patient separately to burns unit, because if we put him in general ward, we have all the organisms thriving happily in general ward. So we don't prefer that. To prevent that and to manage burns adequately, we prefer shifting the patient to burns unit. And then we have most important one, that is fluid resuscitation. In pathophysiology, I mentioned severe hypovolemia leads to so many complications. Managing fluid management is very, very important in case of burns. So how to manage? We have Parkland's formula for this, Parkman's regime, that is most commonly used, 4 ml into percentage of burn. How to calculate percentage of burn, we already saw. And then into body weight for 24 hours. This much fluid is required for 24 hours. That is 4 ml into body weight into percentage of burn for 24 hours duration. The maximum percentage considered is 50%. Half of the volume is given in 88 hours and rest is given in 12 hours. The maximum percentage considered 50% is mostly the textbook is talking about the percentage of burn. The half of the volume is given in first 8 hours. In this, we'll get a number, divide it by 2. Half of it you give it in first 8 hours, and then remaining half we'll give it in next 16 hours. So for 24 hours, we managed fluid of the patient adequately. So in the initial first 24 hours, crystalloids should be given. Crystalloids are one which pass through capillary wall like saline, either hypo or iso or hypertonic dextrose or ringer lactate can be given. In first 24 hours, we prefer giving ringer lactate or hypo or iso or hypertonic solution saline. And after 24 hours, human albumin is ideal colloid. Colloid should be given to compensate plasma loss after 24 hours. So we discussed how much fluid should be given. Now we are telling what fluid should be given. What is the fluid that we are infusing to the patient? In first 24 hours, more than 24 hours. First 24 hours we are giving crystalloids. After 24 hours we are giving human albumin, so that we can replace the plasma proteins which are lost in burn due to increased capillary permeability. This is about fluid management. Then we have local management. Under local management, we have dressing at regular intervals. Under general anesthesia, using paraffin gauze, hydrocolloids, etc. If the burns are severe, we should manage it under general anesthesia. So the local management, we have two methods, that is open method and closed method. Open method is is application of silver sulfadiazine without any dressings, used commonly in burns of face, head and neck. Here what we are doing in open method of local management, we are just applying silver sulfadiazine cream to the patient. Most commonly is done is head and neck and face region is involved, because you can't put the dressing into the face of the patient. No, silver sulfadiazine. Then we have closed method, that is dressing. Dressing is done to soothe and to protect the wound and reduce the pain as an absorbent. So wound coverage, we have once the burnt area heals, usually which is after 3 weeks, we consider split screen grafting to the patient. That's it. This is all about burn. I think we have got adequate points to write 10 marks question in this presentation. So we saw classification, pathophysiology, clinical manifestations, and treatment. Pathophysiology and classification I summarized many times, so I'm not summarizing again. Clinical manifestation, let's discuss about tangential excision. What is tangential excision? I think the term is self-explanatory. The tangential excision means the tangential excision of the burn area with skin grafting can be done after 48 hours in patient with less than 25%. It's usually deep dermal burn wherein dead dermis is removed layer by layer until fresh blood comes out. Later skin grafting is done. Tangential excision is, it is done in case of deep dermal burns. Kaushik, please mute yourself because I'm hearing the audio. Deep dermal burns, that is deep second degree burn. If the patient presents within less than 48 hours and the area of burn is less than 25 hours, we can consider tangential excision. Now, what is this tangential excision? Tangential excision is removing the skin, that burnt area, layer by layer, remove layer by layer until we see fresh bleeding. Following that, we'll do skin grafting. Normally, we saw in case of burns, after the burns heals, that is granulates after 3 weeks, we prefer split screen grafting. In case of deep second degree burn, if the patient presents within 48 hours and the area of burn is less than 25%, we can consider tangential excision, where the skin is removed layer by layer until we see fresh bleeding, and then following that we'll do skin grafting. What are the advantages of this? It reduces the chances of secondary infection, the most important point. Secondary infections, we already saw secondary infection, MODY and SARS associated with it. It reduces that. It reduces the hospital stay and also the formation of hypertrophic scar and contracture is reduced. Is reduced. The formation of contracture and hypertrophic scar is reduced. So this is about tangential excision. Kaushik, understood tangential excision? You can unmute and tell whether you understood tangential excision. Okay, done.
Yes, Kritik, understood.
Okay, thank you. Thank you for spotting it out.
Okay.
Okay, I was summarizing clinical manifestations. Clinical manifestations related to burnt area, that is first degree, second degree, third degree, and fourth degree. Following that, we saw systemic manifestations, pulmonary, renal, GIT, and infections. Following that, I talked about management, first aid, tap water, continuous irrigation. Please note, not cold water. Don't recommend ice water. Please. Ice water. No. Tap water, continuous irrigation for 20 minutes. I'm telling this because we considered it in one of my family member had burns. We thought that giving ice water continuous irrigation may help. So I am recommending, I am telling it now, please don't do it. Do tap water continuous irrigation. And then followed by administration of tetanus toxin, then dressing. And also definitive management, ABC. First point you should mention is airway breathing management. The special case if face is involved, if there's good singeing of nasal hairs, vibrio-ACA, we will consider endotracheal intubation or tracheostomy. That is life saving. The management of patient in burns unit, and then followed by fluid management. Parkland's formula. Parkland's formula I will once again mention because it's very important. That is 4 ml into percentage of burns into body weight if the percentage of burn is 50%. Please note this. And then divide it by 2, give 50% divide it by 2 and give 50% of it in 8 hours and next 50% in coming 16 hours. What are the fluids which are given? In first 24 hours, we'll give crystalloids. Next 24 hours, we'll give human albumin to replace the lost plasma proteins. And also, we saw the definitive management, the local management. Where's the local management? Yeah, local management. We saw open methods and closed method. If the head and neck and face is involved, we'll just apply sulfasalazine and manage. And also in case of first and second degree burn, see if there is first and second degree burn, first degree burn and partial superficial second degree burn, you can manage it by giving sulfasalazine. And mostly the patient will not present to hospital also in that case. That's another point. And also the closed management where we do dressing. After 3 weeks, we see for granulation tissue, and then we'll do split screen grafting. And also upon Kaushik request, we cover tangential excision. That is done in case of deep second degree burn or deep dermal burns, where if the patient presents within 48 hours and if the area of burn is less than 25%, we'll remove the skin layer by layer until we see fresh bleeding, followed by split screen grafting. What are the advantages of it? There is reduced chances of contractures or hospital stay, and there is reduced chances of hypertrophic scar. This is all about burns. So we completed with burns. This one, rule of 9 in burns, we all know. Wallace rule of 9. Fluid resuscitation in burns, we all know. 50% burn in 50 kg patient. Okay, here they are mentioning more than 50%. Wait, 1 minute. Not more than, they are given 50% of burn. Whether this formula applies or not, we should see. Since less than or equal to 50% of burn, we can apply Parkland's formula. We'll proceed with Parkland's formula. So if the examiner gives more than 50% formula, then what is the management, fluid management? So let's learn other formula, or let's also have other formula in our bucket list so that we don't miss the question. That is Muir and Berkeley regime. That is for colloid after 12 to 24 hours. This only for colloids. Muir and Berkeley regimen is used in only case of colloid. What does it tell? Amount of colloids required is percentage of burn into body weight in kg divided by 2. It's equal to 1 ration. So we should give 3 rations in first 12 hours, 2 rations in next 12 hours, and 1 ration in another 12 hours. So what did I say? We saw Muir and Berkeley regime for colloids, which is given more than 24 hours usually. That is percentage of burn into body weight divided by 2 is 1 ration. We should do into 3 and give it in first 12 hours, into 2 and give it in next 12 hours, and 1 ration will give in following next 12 hours. is another formula for an emergency rescue. So here you apply Parkland's formula and calculate it. It's very simple mathematics. Facial burns, we explained. We saw what should be done in case of facial burn management. And you can mention briefly about clinical manifestations and management here. Second degree burns, we saw deeply. Assessing surface area of burn, we saw. Wallace rule of line, we saw. Curling ulcer also we saw. This is green. Also toxic shock syndrome also we saw. Green. Fluid replacement in burns we saw. Parkland's formula in burns we saw. The hysterotomy in burn wound is remaining. I will mark it red. It's asked only once, so I am skipping it. Can you read hysterotomy for yourself? Okay. And at last we have electrical burns and acid burns. Electrical burns is asked 3 to 4 times. We'll discuss electrical burns and we'll skip acid burns. By discussing electrical burns, we are completing with burns chapter. Electrical burns. Give me 1 minute. Okay. Discharge contractures in burn. Electrical burns. I'm starting with electrical burns now. There are 2 types of electrical burns. That is low tension injury and high tension injury. Low tension injury is seen in less than 1000 volts power electricity. High tension injury is seen in more than 1000 volts injury. Please remember, electrical burns is always deep burn. That is deep second degree burns and above it. We have entry wound and exit wound in electricity burns. Entry wound and exit wound. In the entry wound, we have jaw burn, which is the characteristic point which will help us to identify the entry part of the site of entry of electricity into the body. The patient may also have major internal organ injuries, GIT and thoracic injury. Okay, we'll see by in few minutes. Often convulsions can develop. Yes, convulsions can be there in patients. So clinical manifestations, above we have deep burns. And also systemic manifestations, we have CNS convulsions, and hearts we have arrhythmia. Please note why arrhythmia, because the person will be standing below the tree thinking of something or dreaming. Suddenly rain comes, electricity enters here, goes here and exits here, and the person will also exit to the Swarga. Here when the electricity comes from entry point, if it passes through the cardiac area, we have pacemaker, we have electrical activity inside the heart. It will get instantly disturbed and it may lead on to arrhythmia and death. Okay, that is arrhythmia. And also gas gangrene is common in case of electrical injury. Gas gangrene is common due to Clostridium perfringens infection following the burn. There is release of myoglobin, which can cause what it will cause. Acute tubular necrosis. We already know. We touched it 2 to 3 times from past 3 days. Acute tubular necrosis leading on to acute renal failure, and the patient may have acidosis, which should be corrected with bicarbonates. And also, we should do continuous ECG monitoring because the patient has arrhythmia. The important point is mefenide acetate. It's an agent which penetrates well, and it is useful against clostridial infection, which causes gas gangrene. Please note this point. The mefenide acetate, it penetrates deep into the skin, and it helps to treat the clostridial perfringens, treat the clostridial perfringens infection. Perfringens infection. So we saw electrical burns, two types: low tension and high tension, less than 1000 volts, more than 1000 volts. Clinical manifestations we saw: at the site of burn, there is entry wound, exit wound. At the site of entry wound, we have jaw burn, where the whitish parchment-like tissue, necrotic tissue, due to the initial resistance offered by the skin to the electric flow of electricity. We see that white parchment-like tissue, that is entry wound. Then we saw systemic manifestations, convergence, arrhythmia, acute renal failure, and then most importantly, gas gangrene. How to manage it? Mefenide acetate, and then under investigation we should do continuous ECG monitoring, continuous vital monitoring, and also in case of infections we can do culture and sensitivity, blood culture and sensitivity, and you can write many infections because we have many systems involved, and we can elaborate on it. And under treatment, we see if the patient has convergence, manage the convergence. If the patient have arrhythmia, manage it adequately, manage it by electrocardioversion or other measures, continuous ECG monitoring, and also we can give antiarrhythmic drugs, antiarrhythmic agents, and then we saw how to manage Clostridium perfringens infection, mefenide acetate. This is about electric burn. So we have successfully completed burns chapter and in surgery.